Good evening, everyone. We are now going to talk about knowing and owning your change. And we're going to start the conversation about perimenopause and menopause with a focus on Black women's experience. This panel that you're about to hear is designed to foster an open and honest dialogue and raise awareness of our unique needs around perimenopause and menopause. So I have a series of questions, and here with my distinguished panelists, thank you all for being here tonight. And the first one I'd like to ask of Alicia and Michelle. And we are eager to hear about your experience with perimenopause and menopause. And could you tell us a little bit about the strategies that you've used to cope with the change?
Yeah, overall, thank you. My experience has been mild. Um, However, I think looking back, my symptoms started earlier than I thought, and I was a bit confounded because a lot of the women that I was talking with had children, and so their symptoms were different than mine, so I didn't recognize I was in that phase. And I think when I knew a little more, the strategy that I sort of formed the basis of my strategy was actually to know my numbers as my body changed. Like, was my heart, my blood pressure, all of those things, were they uh, doing well? And so I looked into that, and that helped me develop different behaviors that I needed to ensure that I stayed healthy physically and felt well.
Hi, good evening, everyone. My name is Alicia. I'm currently going through medically induced menopause due to breast cancer. So I'm not sure if it's the same, but for me, it's hot flashes, mood swings, the weight gain, especially around the tummy area, the sleep disturbance, the low libido, and the vaginal dryness that was also mentioned. Everything that was mentioned in the video that we saw. The way that I try to combat all of those is to eat a balanced diet. I try to work out as much as possible. Um, my go-to would be walking for an hour each day. I try to limit my screen time before bed so I can have no sleep disturbance. Um, a fan everywhere I go is my number one thing. But I just try to be positive. I'm constantly having hot flashes, but I just try to be positive. I don't try to be negative about it or be down on myself about it. Thank you.
Alicia and Michelle, thank you very much to both of you for sharing some of your experiences, and I already hear you talking about some of the solutions. I wonder if we can turn to Jessie Bawden. Jessie, hello. And I'd like to hear from you as a nurse practitioner, as a clinician, what you think our patients can do if they are experiencing symptoms of perimenopause or menopause, and when should folks start to seek professional help? And what questions should they be asking?
Yeah, really good question. Good evening, everybody. Thank you so much for having me. I think it's important to point out not all women, as they go through the menopause transition, will experience symptoms that require medical intervention. And I hope that many of you sail through it, as Leonie mentioned in the video. But I do think that if symptoms are affecting your function, affecting your quality of life, affecting your ability to sleep and function well at work and socially engage in your communities, and if you're in any emotional distress, this is a reason to seek help with a healthcare professional. There are many treatments available. The common symptoms like hot flashes, night sweats, and vaginal and bladder changes, those are kind of the ones we know we can help you with for sure. We can reduce the rates of hot flashes by 75% using hormone therapy. And for women like Alicia, where that wouldn't necessarily be appropriate, we do have new medications that are coming down the pipes that are non-hormonal and can help with hot flashes. So there's lots of treatments available. I think as you prepare for your appointment with your healthcare provider, you want to have some data. So please do track your periods, either create a little spreadsheet or put a note in your calendar or have an app on your phone that you can track your symptoms when they happen, make a note of the severity if they're happening more frequently, but also the details around them, right? Like telling your physician or NP that you're having 7 to 10 hot flashes a day or more than 50 a week, that's severe. And if you have new menstrual bleeding where you're doubling up on pads and tampons and you're having to change throughout the night and set an alarm, that's unusual, that's abnormal. And we need to know those details so we can design a treatment plan. Some of the questions you might ask might include, what stage of menopause am I in, right? Keisha asked in the chat, is there testing for perimenopause? And the diagnosis is actually based on your bleeding changes, right? We treat your symptoms regardless of where you are in the transition. So there's really no testing needed most of the time. If you experience early menopause and a few other situations, we do hormone testing. You want to also ask your provider, what should I expect? What does the next few years look like? Someone asked, does postmenopause last forever? The answer is no. Our symptoms kind of group around that final menstrual period. And then the symptoms that last forever, like Dr. Sheila Wijayasinghe mentioned, are those vulvovaginal changes, the dryness, the bladder. Unfortunately, that is till death do you part. So, and if your doctor or your NP can't answer the questions you have or give you the answers that you're looking for to Candace's question, if you're being dismissed, you need to get another opinion. And I know that that's difficult in the healthcare climate right now, but I do encourage you to advocate for your health. We hear so many stories of women especially pushing and getting the care that they need, and it was the right care for them. So really important conversation, and I could speak about this all day.
Thank you so much, Jessie. That was some really practical information for all of us to take away from this session. Also, I'd like to draw folks' attention to the chat. You'll find many resources flashing through the chat that you can download and hopefully add to your educational library about perimenopause and menopause. So we've talked quite a bit about the symptoms of menopause, some of the potential treatments and approaches to managing those symptoms. And I'd like to now shift a little bit to some of the other kind of prevention and health considerations that we should be aware of, and ask if Dr. Sheila Wijayasinghe could tell us a bit more about how perimenopause, and menopause affect overall health if you are a Black person, and if you could touch a bit on heart health, bone density, and mental well-being, that would really be appreciated.
Thank you, Dr. Maxwell, and hi, everybody. So really important. As a family doctor, a lot of what we do is around preventative care for our patients. And when we think about menopause, there's a lot of focus on the symptoms. And Jessie went through those so beautifully, and I know that many of you are ticking all those boxes, like I said during my talk. There's a lot of symptoms, but it is really important to think about preventative care because we know that chronic diseases and the risk factors for those diseases, including heart disease, bone density changes, all can increase during perimenopause and menopause. And this is where it's super important for us to have this discussion because, again, symptom management is important, but also knowing what your risk factors are. And specifically when we talk about heart health, menopause does increase, and this is a time, especially in menopause transition, where we see cardiovascular or heart risk factors increase. So specifically, we see things like high blood pressure can increase, your blood sugar can increase, cholesterol levels can change, and we think this is in relation to changes in our estrogen levels. And unfortunately, Black women are disproportionately affected by heart disease. And so this is where, just like Michelle actually mentioned she knew her numbers. And that's what we really focus on with my patients. I say, let's know what our numbers are. So know what your blood pressure is, know what your cholesterol levels are. There's a new marker that we use called lipoprotein A, which we also can test for. There's a number of things that your doctor or nurse practitioner can test for, and tracking those things over time can be very helpful to reduce that risk. We also know, as I mentioned during my talk, that chronic stress, structural racism can also contribute to something called allostatic load, which is sort of the wear and tear on the body of chronic stress. And that we think also probably plays a role as to why Black women are disproportionately affected in terms of heart disease risk. Bone density is also really important, Dr. Maxwell, in terms of maintaining, because we lose our bone density, especially in menopause transition, and it increases, why we worry about this is that it increases the risk of fractures. And if any of you have had anybody in your life who have had a hip fracture in particular, we know how significant this can be in terms of your mobility, your ability to get around. And we know that in the first year after having a hip fracture, mortality or death rate actually is quite high. And so we're really focusing in your 40s, 50s, and 60s on maintaining, getting your bone density to a good, strong level to protect yourself for later on in life. And why Black women are disproportionately affected by bone density changes, Black women start with a higher bone density prior to menopause than white counterparts. But what happens over time is that because you go through menopause earlier, there is less estrogen, and estrogen has a protective effect on the bones. And what we see is because of that earlier onset of menopause, there can be actually a more significant effect on bone density during that menopause transition. So that's why it's important to know your risk factors. We have a risk calculator called the FRAC score that you can do, and then understanding what your risks are. And if there is a concern about bone density risk, especially if a family member has had a fracture, a hip fracture in particular, you can get that support early on to deal with that. The final piece really quickly is around mental well-being. There's an increased risk of depression and anxiety during menopause transition. And this is really, we see this also disproportionately affect our Black patients, in particular due to potentially reduced access to mental health care, the social and economic stressors that you may experience, and also difficulty in accessing care and addressing these needs directly. So those are my I think I answered the first question. I don't know if there was a second question.
You answered quite a bit. That was so helpful to really dig deeper into the different areas of our health where Black women really need to be aware of the potential impacts of menopause and perimenopause. Just on the topic of the symptoms of menopause, so the things that you talked about earlier, the hot flashes, sleep disturbances, things of that nature. Are Black women expecting to have a difference or experience those symptoms with a different kind of severity than people from other communities?
Yeah, that's a wonderful question, and really why we need to address this. I'm so glad that we're talking about this today because, as I mentioned, Black women can experience menopause transition earlier, and as a result, you may have longer onset of perimenopause as well. And perimenopause is a time that's sort of predictably unpredictable, and so you may spend more time in that period of time where we see fluctuations in symptoms and more severe symptoms. We know that Black women experience hot flashes more often and for a longer duration, on average about 10 years compared to the average of about 6 years for other populations. And that is really a big struggle. And relating back to hot flashes also, the severity of hot flashes also can give us a bit of an indicator of heart disease risk, actually, and we don't talk about that enough. So the more severe your hot flashes are, there is an association with heart disease risk as well. So definitely, because we're seeing Black women enter menopause earlier and they may spend a longer time in the perimenopause transition, the symptoms may be more severe and longer duration, which is why we need to address it. And that's why we're here. And then also addressing the health equity considerations that we are also addressing, Dr. Maxwell, around, structural racism, medical mistrust, those sorts of inequities, they contribute to difficulty with access. So hopefully by reducing the knowledge gap, that will be one step towards supporting our patients.
That's so helpful, and I'm so glad that we're holding space for this discussion and to help support members of our Black community going through the change. I'd like to now focus a little bit on the issue of sleep. That's come up several times, both in the video reel and in the keynote presentation by Dr. Wijayasinghe a few moments ago. And so I'd like to ask Dr. Woganee Filate about the issues that impact our sleep. What is the relationship between perimenopause and menopause? And I wonder if you could tell us a bit about the hormonal changes and how those actually affect sleep quality.
Thank you so much, everyone. So sleep disturbances at this time are really profound. Up to 60% of women in the menopause transition will report changes in their sleep. And for many of the women I see in my office, it often comes as a surprise. They maybe never had problems with their sleep before, and then all of a sudden they're having difficulty. And that can be ranging from difficulty falling asleep, difficulty staying asleep, waking up earlier than your bedtime. Than your wake time that you're normally used to. So when I talk to patients, I like to think about it in 3 buckets. So there are 3 main categories why we're having difficulties with our sleep. And the first relates to what you were saying about our hormone levels. So we know that estrogen and progesterone play a big role in our sleep quality. We know that estrogen helps us to have good deep REM sleep. That's the sleep that you want, usually between 3 o'clock in the morning and 6 o'clock, that when you wake up from, you feel quite rested. And estrogen ensures that we have nice long stretches of that REM sleep. As our estrogen levels go down during perimenopause, we lose that consolidation or that long stretch of REM sleep, and our sleep is more what we call fragmented. Many women will report all of a sudden waking up at 3 a.m., 4 a.m., 5 a.m., and not having an understanding why. And so we can relate it to the lack of REM sleep. Estrogen also in and of itself can lead to more awakenings at nighttime. And progesterone is another hormone that declines during this time. And the progesterone hormone is really our feel-good, sedating hormone. So as that hormone goes down, it's harder and harder to fall asleep and stay asleep. The second bucket that I talk about and how this transition affects our sleep is as it relates to hormones or menopausal symptoms, especially hot flashes and night sweats. I have many people tell me that they keep multiple bed sheets by their bed, pajamas, extra pajamas, because they wake up in such a sweat, and it's quite disturbing. So if you have hot flashes and night sweats, you really want to have those addressed, because that will improve your sleep. And the more frequently you're having hot flashes at night, obviously, the more disruptive your sleep. And then the third bucket that I think many women don't often have on their radar, and this is oftentimes a discussion I have with them, is that we become more at risk of obstructive sleep apnea during the perimenopause and menopause transition. And that's because we know estrogen also plays a role in the tone of our muscles in our airway. So as we transition through menopause, the airway becomes more, as I say, floppy, for lack of a better word, and we're more likely to have airway obstruction. And women will often say, well, I don't think I have sleep apnea because maybe I don't snore very loud, or no one has told me that I wake up gasping for air. But for women, it can often be what we call non-specific symptoms. So things like waking up tired, headaches in the morning, and difficulty concentrating. So those are the three main reasons that sleep becomes a real challenge during the menopause transition.
I think this is incredibly helpful information. I think sleep is certainly one of the areas where your health can be impacted in so many different ways. All of your body functions depend on good sleep. So we heard about the tropical moments that Elaine referred to earlier on in the video. You've mentioned already some of these in your first response here, but can you talk a bit more about strategies, lifestyle modifications, medical interventions, bans, and things of that nature that can help mitigate the sleep disturbances?
For sure. So firstly, I heard it in the video before this panel that really moved me was one of the women talked about prioritizing sleep. So it's such an important time to focus inward and to protect sleep as a really big pillar of your overall health. And so what does that mean? That means making sure that you're setting aside enough time for sleep. Be careful of what I call sleep stealers. So this includes telephone use or your cell phone use before bed, having your computer, working late into the night on your cell phone. I loved how someone in the video also talked about she got back into reading and as she was prioritizing her sleep. So really trying to avoid things that disrupt our sleep. Other things, look at your diet. So be careful and mindful of caffeine late in the day. That can definitely interfere our sleep. You may all of a sudden become more susceptible to caffeine late in the day. That will affect you going to sleep. Be mindful also of alcohol and how it disrupts our sleep as we get older specifically, and to really think about things that you can participate in before bed that will help relax you, relax your body, relax your mind. I've given many patients tools such as online meditation or sleep stories before bed to help relax them. For women who are struggling with hot flashes and night sweats, it's really imperative that those get treated, because no matter what we talk about lifestyle interventions, if you're waking up 3, 4, 10 times at night because of hot flashes, you're going to need to have those addressed and treated with your healthcare provider to really ensure that you return to getting some good sleep. And if you are worried about a more serious sleep disorder, if you're concerned about sleep apnea, for example, or an insomnia disorder, work with your healthcare provider, your primary care provider, your nurse practitioner, and consider referral to a sleep specialist for more in-depth testing and treatment.
Thank you very, very much. That was incredibly helpful. We are going to shift gears slightly away from sleep, and we're going to talk about a very important part of the body, one near and dear to my heart as an obstetrician gynecologist, and that is the pelvic floor. So Olivia, you are a specialist in the pelvic floor, and we would love to hear from you as to your thoughts on the impact of perimenopause and menopause on the pelvic floor. What is the impact? Why do we need to be aware of this?
Yeah, thank you so much for that question. And before I begin, I just want to acknowledge, as a white woman speaking at this year's Best Health for Black Women event, I want to recognize that my experiences and perspectives come with privilege, and that privilege has afforded me, among other things, greater access to healthcare, education, and research that hasn't been equally available to Black women. And as a pelvic physio here, my role is not to prescribe, but to listen and learn and to share knowledge in a way that is supportive, culturally responsive, and trauma-informed. And by no means do I have the full picture on menopause and pelvic health, but I come here to humbly share what I do know in hopes that I can help improve the lives of others. So we know that menopause is far beyond the end of menstruation. It is a profound shift that impacts nearly every system in the body, including the pelvic floor. And our pelvic floor is a complex network of muscles, ligaments, and connective tissues that support our bladder, uterus, and rectum, and it plays a crucial role in sexual function. And when estrogen declines during perimenopause and menopause, it causes a cascade of physiological changes to occur, and it can affect pelvic health in several ways. So the impact of estrogen loss on the vagina, the vulva, the urethra, and bladder is known as genital urinary syndrome of menopause, which we've discussed already through this evening. And that can affect around 50 to 65% of women within 7 to 10 years after menopause. And despite its prevalence, only 25% of women seek treatment. So we do see a reduction in collagen and elastin in the genital urinary tract, leading to decreased vaginal and pelvic tissue elasticity. But we also see other common symptoms such as vaginal atrophy, vaginal dryness, irritation, burning, itching of the vulva and vagina, even recurrent urinary tract infections, and pelvic floor dysfunction. And with this reduction in estrogen, we can also see other sexual health symptoms such as the reduction of sexual desire due to discomfort or pain during intercourse, decreased lubrication, postcoital bleeding, all of which can lead to changes with arousal and orgasm. Now, sexual health can be influenced by more than just hormones. We can see some social changes, body image concerns, and other coexisting medical issues or medication that can also play a role. And many individuals experiencing these issues may be afraid or ashamed to discuss with their primary care provider or family members, leading to individuals feeling like they live in silence, maybe avoiding the conversation with their partner, and that can lead to further strain in relationships. So as a strategy to help with those, we can look at water-based lubricants, vaginal moisturizers, things that include hyaluronic acid or vitamin E. We can look at vaginal estrogen, DHEA therapy may improve vaginal tissue health. And we can also look at devices, things like pelvic wands, accommodators, things like the O-Nut. These can be really effective tools in enhancing comfort and addressing these concerns. Now, menopause symptoms like sleep disturbances, chronic stress, even decreased insulin sensitivity, which contributes to increased abdominal weight gain and intra-abdominal pressure, all of those things are also going to impact pelvic health. And we also know that these factors can also raise the risk of other health conditions as well. So we want to be mindful of those things. So we can see that menopause is more than just a phase, and it's a significant transition that deserves attention, education, and proactive management. And I think it's very crucial to center the lived experience of Black women in the conversations, because I feel that, their stories, their voices, they need to be heard. We want to be able to advocate for that equitable healthcare, increasing representation and research, and really ensuring that culturally competent care becomes the standard, not the exception.
Thank you so much for your thoughtfulness in your responses and the great information that you've shared with us already. You've already touched on a number of strategies and devices and wands and different things. I just wonder, are there any other points or strategies, takeaways that you want us to know about to improve the health of the pelvic floor?
Of course, there's so many things with the pelvic health. Well, oftentimes Kegels can often be seen as the go-to solution for pelvic floor issues. They're not always the right answer. Pelvic floor dysfunction can stem from weak muscles, tight muscles, or maybe a combination of both. So if muscles are overactive and tight, doing Kegels might actually worsen your symptoms. So that's where having a pelvic floor assessment could be beneficial. Pelvic health physiotherapy is an evidence-based first-line treatment for issues like urinary incontinence, prolapse, pelvic pain. And when pelvic floor tightness might be a root cause, treatment might focus more on relaxation techniques and then gradually introducing strength training and functional movement afterwards. So should we do Kegels? Maybe, but only if it's appropriate for your body. So we know that pelvic floor dysfunction can be a huge barrier to exercise for women. And for many people, it is coming at a time in their life where they need to stay active the most. So even just other small changes over time can make a meaningful impact. For example, just 1 hour of resistance training per week can lower your risk of metabolic syndrome by nearly 30%. And we can drop high cholesterol levels by 32%. And that's just 1 hour a week. That's so powerful. And we have lower body strength, if we think of our lower extremities or legs, strongly connected and linked to better cognitive function and lower risk of depression in midlife women. And not to mention, resistance training has been shown to reduce hot flashes by up to 44%, and that's nearly half. We need resistance exercises to maximize our bone and muscle strength, so lifting weights, body-weighted exercises, tie in some spinal extension exercise, high-intensity interval training, even balance training. And we're going to work on improving postural stability, which is going to help prevent falls and fractures. Other things we can think of is multi-directional impact exercises, so things like lunges, hopping, skipping rope, anything that's going to get you moving in different directions is incredibly effective for improving bone density and pelvic organ stability, which is hugely important for lifelong mobility and pelvic health. And then I think if we just talk about stress briefly, because we know menopause that women are experiencing and navigating so many things. We're navigating work, caregiving, aging parents, financial stress, systemic racism, life transitions, and chronic stress can just have havoc all over the body. So I think adding in restorative movement is very, very important, as well as that resistance kind of exercise piece. So mind-body practices like restorative yoga, qigong, or tai chi, using these powerful tools during menopause, it's going to help lower cholesterol, reduce inflammation, it's going to help ease hot flashes, improving your sleep, even supporting our heart health. And when we add that breath work into the mix, the benefits go even further. So how could we put it together? Maybe starting something small like mindful walking, doing some diaphragmatic breathing. There was a study that showed just even 6 to 9 weeks of doing mindful walking and diaphragmatic breathing helped to reduce hot flashes by up to 52%. It helped to ease IBS symptoms like constipation, even just help prevent pelvic floor dysfunction moving forward. So if you take it outdoors, you go for a walk in a green space, get some natural light at the back of your eyes. It's also going to help reset in your circadian rhythm. It's going to help boost your energy, improve your sleep, and even support your gut microbiome. So lots of great things that you can do, just small measurable change over time.
Thank you so much for the incredible information. I'm feeling already so motivated. I'm ready to own the change and hoping to bring everyone along on that journey. Thank you so much. We know that there are so many different things we can do in our lifestyle approach to treat things like, or to support things like our pelvic floor and our sleep, as we've heard already. But sometimes we need a little more. And so I wanted to go back to Dr. Wijayasinghe, if I may, with a question around hormone replacement therapy. When does that come into the picture? And, is it for everyone? And could you just talk a bit about some of the factors that people should be discussing with their primary care provider when it comes to the hormones?
Yeah, this is a great question. And I think, historically, we ignored menopausal symptoms in our patients. And certainly I was one of the generation of clinicians who was taught not to treat menopause. And as such, we were told, don't even ask about it because we don't have treatment options. And now we have treatment options. And I can see in the chat that there are many questions around hormonal therapy, but also non-hormonal therapy. So I'm really glad that you're asking this question. So when I talk to my patients about, is hormonal therapy in particular a good option for you, we look at specifically what are the symptoms that you're experiencing, what are your goals of care, like how are things affecting you, and what are your goals, what's your comfort, because some folks, may not want to be on hormonal therapy or may not want to be on non-hormonal therapy, and what are your personal risk factors. So I always go through things like we discussed before, like your cardiovascular health risks, we talk about breast cancer risk, we go through your bone health risk, and we have a full discussion to review what your risk factors are. And then we look at timing specifically with hormonal therapy. And so we know that hormone therapy is considered to be mostly safe when we start it before the age of 60 or within 10 years of going through menopause. And menopause is being that 1 year without having a period. Starting hormone therapy later than this may increase our cardiovascular risk factors or heart disease risk factors, which is why it doesn't mean that it's not possible to start it after this age, but it does mean that we have to do a very careful and thorough review of your heart risk factors when we are considering this. When we think about local hormonal therapy, that again, we can start at any age. And so there's a question in the chat about, let's talk about post-menopause. Once you go through menopause, that 1 year, you are then considered to be in post-menopause. And I always tell my patients, I say, listen, hot flashes tend to get better over time. Brain fog tends to get better over time. The genitourinary syndrome of menopause, the vaginal changes, the bladder changes are the symptom complex that tend to get worse over time if we don't address it and treat it. And local hormonal therapy can be started at any age. And so that's one piece around timing. And then we always go to like, what are the symptoms that we're trying to target? It's very effective, as Jessie mentioned, for hot flashes. It's the most effective treatment that we know, hormonal therapy, for moderate to severe hot flashes and night sweats. And then similar to Dr. Filate, like this is where it can improve sleep. It can improve mood if we're addressing the symptoms that are affecting your sleep as well. And this is where it's really important to consider these things. So it's a big discussion, and no one person's experience of menopause is the same. And your goals of what you wish for and what you've experienced yourself are going to be different than your friends' experiences are. But that's where it's really important to think about your symptoms. How is it affecting your life? What are your risk factors? And what are your goals of care? And our role as your clinician is to help guide that discussion and make sure that you're getting the care that is in line with what is best for you and what you feel most comfortable with. And it's really shared decision making. And one other thing, cost is always something that I always talk about also with my patients. There are different types of hormonal therapies that are available. It's important, if cost is an issue, please do let us know, because there are different formulations that are effective. It's just helpful for us to know if cost is an issue so we can work with our pharmacy colleagues to make sure that you're getting that treatment. And I know we're asking about hormonal therapy and when to start it, but non-hormonal therapy, there are very effective options as well for those who cannot take hormonal therapy. And I think sometimes the pendulum is swung so much to say everyone needs to be on hormone therapy, but the truth is that you may not be able to be on hormone therapy due to health history, and there are options available for you. So please, social media can be a place that does sound like very heavy on hormone therapy, and that's not the only option available to you.
Yeah, that's incredibly helpful, and you really outlined a lot of options and things for us to consider, so we thank you for that. You mentioned social media and the internet as probably being areas where people gather information about perimenopause and menopause, and so I think that brings up the issue of being able to speak to experts or having access to clinicians to help guide us on the journey through the change. So I want to ask you, Jessie, if I may, what do you think about so patients who are experiencing symptoms of menopause or perimenopause and don't have access to a family doctor or a nurse practitioner or other clinician? What are your thoughts or suggestions on that?
Yeah, I mean, what a tough question. I'm so glad it came to me. It's a really important but very tough question. I want to say, I unfortunately don't have a real answer to the primary care crisis in Ontario. Primary care, which is, access to family doctors and NPs, It's the front door to the healthcare system, and too many people are locked out right now. We know that this lack of access also doesn't affect everyone equally. Black women are disproportionately impacted by gaps in care, and that makes the conversation even more urgent. I'm a nurse practitioner in primary care, so I'm fortunate to work in a team where I can impart my knowledge, which, I've done extra education and kind of sought out this area of specialization. So I'm able to mentor my colleagues and also the learners that are coming up. And, I think the good news is that it's starting to shift. Medical and nursing schools are including menopause care in their curricula, and this is changing. And I am hopeful that women will start to see more OHIP covered sexual health clinics that are offering menopause care, even walk-in clinics that can get the ball rolling on menopause care. Ultimately, if you need to see a specialist, if your symptoms cannot be managed by a primary care provider, then an obstetrician or a gynecologist or an endocrinologist that specializes in this care requires a referral, and that can definitely be a barrier to care. So the good news is I do think this is changing. I do think that, we want everyone here today to know that there are people working very hard to change this, and we see you and change is coming. But we can consider other options. So there are community health centers throughout this province, ones like Women's Health in Women's Hands, which is just down the street from us, where you could access care that's OHIP covered, a referral from a walk-in to a specialist like I mentioned. And if it's financially possible, there are lots of private options that are evidence-based that are popping up around the city. But I do think that the root cause, which is the education in our system, is changing, and I'm really hopeful that we're going to see better care coming soon.
It's really helpful to hear those perspectives, and thank you for that guidance. We do want to hear from Alicia and Michelle one last time about their experience, but just briefly, Jessie, could you say anything else about maintaining a healthy lifestyle, diet, exercise, stress management considerations that we should keep in mind?
Yeah, for sure. This is, to the point of if you don't have access to primary care, there's so much self-management. Dr. Wijayasinghe mentioned quite a few, and Dr. Filate as well, with how to incorporate nutrition, which is so powerful. It's not just about cutting things out, it's about nourishment. Food is deeply cultural and joyful. So how can we build on the healthy traditions that you already have, like incorporating perhaps more greens, beans, and whole grains in a way that feels familiar and not restrictive. Movement, it doesn't have to mean going to a gym if that's not welcoming for you. It can mean dancing, walking with friends, singing at the top of your lungs. You just want to get a bit of a sweat on, and you want to try to challenge your joints and challenge your bones to prevent osteoporosis. For women that may face extra stress from systemic pressures, movement, it's not just physical, it's also very liberating. When we talk about stress, we're not just talking about like, I had a bad day. We're talking about chronic layered on stress that can build up over years. So the truth is stress management is a lifestyle and behavior modification that you can make. But it's not really one size fits all, right? It could be any of the things I just mentioned, but also learning a few breathing techniques, focusing on mindfulness strategies, getting a good sleep, and really like fueling yourself for just, the life as we have it. And I loved what Sheila said earlier about this time at midlife really being a time of power. So, there's teachings in many cultures about how throughout our lives as women, we kind of fill our basket with experiences and wisdom, and this is really the time to shine. So I do hope that everybody has access to care that kind of reduces that load, and you're able to enjoy your transition through midlife.
That's great. Love that. Let's own our power. And closing thoughts, I'd like to turn to Alicia. If you could share one best message with everybody listening in tonight, what would that be regarding menopause and perimenopause?
My last message would be it's nothing to be ashamed of. I would speak up if I were you, if you're going through this. Don't do it alone. If you need to seek medical attention, then definitely do that. There's lots of women going through this, and you're not the only one. Thank you.
Thank you. So empowering. Thank you for that. And Michelle, you have the final word, the message you'd like to share with the audience about perimenopause and menopause.
I mean, I guess to be candid, it scared me. It still scares me sometimes. But the message sort of to my own heart, and maybe it'll resonate to someone else. I keep telling myself I'm more than a collection of symptoms, right? And so I deserve to be comfortable as possible and to experience this time in a way that is nourishing to my body, mind, and spirit. This is also a really amazing time in a woman's life. Like, I feel more like myself, happier than I've ever been, slightly wiser probably than I've ever been, and better able to show up. And I think as we move through our lives in our beautiful melanated bodies, I think about this nugget attributed to traditional Indigenous wisdom, and it goes like this. At her first bleeding, a woman meets her power. During her bleeding years, she practices it. At menopause, she becomes it. So I just like to say to us all, we're beautiful, we're powerful, we deserve to be comfortable during this amazing second half of our lives, and that we as Black women, that we've made it this far through this and going through this menopausal transition. It is resistance. It's a tremendous accomplishment. We're worthy of care. We're worthy of comfort and support as we continue our work of becoming.
That is so powerful. Thank you. And such a wonderful moment of grace. Thank you so much to our amazing panelists for sharing their experience, their expertise, their advice. We have a whole lot of questions, almost as many questions as we have emojis floating off the screen, which I've been thoroughly enjoying during the panel. I know that many of the panelists have been busily replying to some of the questions, and we'll try to get through as many as we can live. So I will go through a few. I did think this might be an interesting one to talk about, and it's the surgical or drug-induced menopause versus the natural menopause. One of our attendees did ask about the age and time period, and if drug-induced or chemo-induced, chemotherapy-induced menopause was different from natural menopause in terms of symptoms. So I think I don't know if perhaps maybe Dr. Wijayasinghe would like to say a few words on this, and certainly I'll open it to the rest of the panel as well.
Sure. That's a great question. So drug-induced menopause, especially for those who are taking something post breast cancer treatment, can have very similar symptoms to the classic symptoms of menopause. So you can get, and some people do notice a little bit more things like joint aches and pains, muscle pains as a result, but you can get the hot flashes very similarly. So it's considered to be similar. The challenge is that because you're taking a drug, it can be more sudden in onset. And generally menopause and perimenopause, it'll be more of a gradual onset of symptoms compared to the chemo or drug induced or even surgically induced. So surgically is certainly overnight that people can go into menopause because ovarian function stops. But with drug induced, it can be a little bit more gradual, but generally faster than naturally the natural process of menopause. Treatment is also varied depending on why you're taking the chemotherapy or the drug-induced, and that's where having those discussions around options is really important because there are options available. And I think there's a lot of focus on, surviving cancer and getting through that time. But then afterwards, it's very difficult to deal with the symptoms and not feel like you have options. And there are options available, and there are new options that just became available for non-hormonal options that are really exciting and will be game-changing for many of our patients.
That's really helpful. Just checking in with the rest of our panel. Does anyone have any other items to add to that? I think that was a fantastic answer.
I'll just add one more.
Yeah.
about the sleep disturbance. So we know that those individuals that have surgically induced menopause also have very abrupt onset of sleep disturbances, similar to what Sheila was saying about the sudden onset of the hormone, like symptoms such as hot flashes. So something to keep in mind for those going through surgical menopause, that the sleep, it can become a big problem.
Thank you for that. We'll have a couple more questions I think that we'll have time for answering. And so the next one is around access. And Jessie, I know you spoke quite a bit to this issue earlier. There is a question from the audience about whether there are specific clinics or resources that are directed towards Black women or that are tailored towards Black women. So if you have any thoughts on this, and I will certainly ask the rest of the panel as well if they're aware. Over to you, Jessie, if you have any thoughts on that.
Yeah, hi, thank you for that question. I did mention Black Women's Health in Women's Hands, or Women's Health in Women's Hands, and that is a community health center that specifically services the Black community, among others. And then I did provide some resources that I found along the way with respect to self-management, that like resources that are designed by women for Black women. I can't pull them out of my head just a second, but I know that we can put them in the chat. And then I was also going to turn the mic to some of our Black physicians. Like Aisha, do you have any comments on resources that are, or care providers that are specifically working in this space?
You know what we might do is try to add that information to our chat in the coming minutes, and then we can explore this further and share with our attendees. But I do think that you've already mentioned some great resources, and hopefully as people become more aware of this issue and more care providers gain expertise, we will see more representation and allyship in this area of menopause care. I do want to turn to one other question because I see that there is a bit of a theme around pregnancy and menopause, which I think is kind of interesting. One of our attendees asked about whether it's possible to become pregnant during menopause. So I'm going to answer that one. I'm going to answer that one. The answer is yes, actually can happen. It's not very likely to happen, but it actually can. And so for folks in the perimenopause, it may still be important to think about contraceptive options. But the other question I think is also around the difference in symptoms, or I guess how menopause presents, depending on whether you've been pregnant before or not. And so I'm not sure, Olivia, if you have any thoughts on this, or if others would like to add to the knowledge here.
I think I'll just add a few things and then I'll pass it around. I think we all have some good things to add to this one. But it is interesting that this is brought up, and I think it's something that's commonly brought up now. Women are having babies later, and that postpartum stage is coming closer to the perimenopausal stage and then the menopausal stage, and it all starts to overlap, and those symptoms start to, or there's a lot of similarities. What we can do is really track. We can track our cycles, we can track, symptoms. And I always say what we measure, we can manage. So really just gathering what information we can, and just bringing that to your team, to your community, to people that you trust, your primary care provider, your pelvic physio, and just being able to utilize those things to help empower you and to help you in improving your function, your strength, your pelvic health. I find like that is just like it's a big thing that sometimes we don't often think about how that can overlap.
That's incredibly helpful. Any other thoughts? Sheila, go ahead. I see you've come off mute.
I just want to tell a story. My patient has given me permission to share this widely, but I had a patient who was 49 and she called me. She's like, I'm in it. I'm through menopause. I'm super excited. I haven't had a period for 3 months. And I said, well, technically you have to go a full year before we can say that you're in menopause. So is there any chance that you're pregnant? And she's like, no. She had gone through fertility treatment, had never been pregnant. And so now she's 58 and has a 9-year-old. And this is where it is still possible. And it's really important to consider this because if pregnancy is not part of your journey in this stage. We often will treat perimenopause, which is that time where we see large fluctuations in your hormones, with consideration of a low-dose birth control pill or the IUD to help sort of manage symptoms. And that will also give you not only symptom support, but it also gives you contraceptive support, because until you go through that 1 year without having a period, there is a chance that you could get pregnant.
Important things to remember as we go through the through this transition in life. I have another question. So folks would like to know about whether there is Canadian data. So we've talked a lot about data from the United States, and there are certainly publications on menopause and perimenopause from other parts of the world. But specific to Canadian data, Canadian studies on Black women and people going through menopause, are we aware of studies that touch specifically on this? I don't think that there are many, but I'd like to open it to the panel for any thoughts or reflections on this.
I can take a swing at it. Maybe Sheila wants to chime in, but unfortunately, the Women's Health Initiative, which was a humongous international study from about over 20 years ago, collected an insane amount of data, and the results were interpreted in such a way that actually moved us away from using hormone therapy. Long story short, that data is still available and it's being reanalyzed. So there's Canadian women within that data. There's not a lot of Black women within that data. Sheila mentioned the SWAN study. That's an American study, but it does have ethnicity as one of their markers. So we're really hopeful to see some good outcomes and guidelines from that study, and it started to come through. I'm thinking about Canadian studies that are like kind of pan-Canadian. I think the Menopause Foundation of Canada has done some good work in the area of the impacts of menopause in the workplace, and they considered ethnicity and race as well. And I'll stop talking because that's really all I can pull out off the top of my head.
I think that's really helpful. Sheila, I don't know if you had anything else to add. I was going to turn to Michelle and Alicia for some for additional thoughts on the impact of any treatments they may have received on getting through some of the symptoms of menopause. So maybe Michelle, I'll ask you if you had anything to share or to inform our listeners about the impact of any treatments that may have helped you with your symptoms.
Oh, wow, that's kind of personal. Yeah, so
only what you're comfortable sharing.
Yeah,
of course,
yeah,
Michelle.
no, it's okay.
Sorry.
We're all a group of women here. Some of the symptoms I self-manage, so like hot flashes, you have a fan or wear different kind of clothing. For vaginal dryness, I have used topical creams, and that's been really helpful. For joint pain, I've done Pilates, reformer, but I've also used, like some topical treatments for, pain when it's been really bothersome. But my symptoms have been fairly mild, so some of these things, they all make me more comfortable, but they don't reverse or eliminate the symptoms. I don't know if that's helpful to our audience.
That's very helpful. And I guess in terms of any barriers you might have experienced in accessing the care, is there anything that you think would be helpful to our listeners? And I'll ask Alicia the same question.
Yeah, I think the barrier is being a Black woman. Even though I work in the healthcare system and I have a, good job and I'm fairly educated, a lot of the menopause discourse doesn't look like me. I also have never had a child, so a lot of the conversations I hear are about the symptoms related to having carried a child to term. And so even that sort of always makes it hard for me to move toward care and talking about my needs and not having a physician that necessarily reflects me.
Yeah. Well, thank you for that. Alicia, over to you. Anything about treatment, barriers, anything that you'd like to add about your experience?
Honestly, I haven't seek medical attention for my menopause because it's due to my treatments that I was on prior and that I'm still taking now. So I think I just try to deal with it myself by exercising, eating better, the fan everywhere I go. But I think after listening to the talk tonight, I might bring it up to my doctor and just ask if there is anything that we can do, even just for the hot flashes. Um, and I learned something tonight. I didn't realize that depending on how much hot flashes I get per day, that could, do something with my heart health later on. So that's very interesting to know. So I definitely will be bringing it up to the attention of my doctor because I get a lot of hot flashes. I'm even getting one right now as we speak. So it's often. Um, yes, as Michelle said, being a Black woman, definitely it's difficult speaking up about this and being listened to, but I'm going to try. Thank you.
Thank you so much. We've learned so much from both you, Alicia and Michelle. Thank you so much for all that you've shared with us, and to all of our clinicians on the panel. Very grateful. Here are some takeaways I think that we can keep with us after our discussion. Perimenopause and menopause are part of a natural transition. They're not a disease. We all need to keep informed about the various symptoms and treatment options, and we shouldn't be afraid to ask our questions. So talk about it, ask about it. It's important for us to self-advocate and to seek help and support, and that we should embrace self-care, give ourselves some grace, and try to shift the narrative from enduring to thriving. So on that note, we will close this panel, and thank you all very much for participating.